Hi, everyone. Good evening, and thank you for joining us for the second event in our Breast Cancer Awareness Month series. Tonight's topic is What's New in Breast Cancer Radiation, Faster, Safer, Targeted Care with Radiation Oncologist Dr. Seth Kaufman. Just a note, we will have time for questions at the end, and we'll be using the Q&A box, so feel free to type questions as they come in or at the end, but we will have a separate, we'll have a time at the end dedicated for questions. So with that, Dr. Kaufman, thank you so much for joining us tonight and sharing your expertise with us, and I will turn it over to you.
Great. Thanks so much, Simone. Really appreciate it. And I appreciate the opportunity to be able to speak with everyone tonight about radiation in breast cancer. As Simone had stated, I'm a radiation oncologist at Bay State, and I have a focus on breast cancer treatment. So it's an exciting topic for me to talk about what's new and evolving in breast cancer treatment with radiation. So just to give you an overview of what we'll be talking about this evening, I just wanted to give you a little bit of background in terms of both breast cancer and the biology and anatomy surrounding breast cancer and how radiation treatment works and works with that for treating cancer. And the traditional ways in which radiation is used for breast cancer treatment, both for invasive disease, which we'll go over, and for pre-invasive disease, or DCIS. And then we'll kind of shift to talking about some of the newer techniques and developments in breast cancer treatment with radiation, using shorter courses of radiation, situations where we have discovered that it is safe and reasonable to skip radiation treatment, and ways that we have to target radiation more precisely through different techniques that you may have heard of. A breath hold technique, which we'll go over, using patients lying on their stomach in the prone position rather than the traditional lying on their back for radiation treatment. The changing of the radiation beam through intensity modulation, which I'll go over, that allows us to sculpt the dose as it is deposited in tissue. And then the use of partial breast radiation, so treating just a portion of the breast rather than the entire breast, and what the indications and potential benefits of that are. So looking at cancer as it forms, in the breast, when we look at the breast tissue, the functional unit of the breast tissue is the lobule, which is the structure that makes milk. And the milk is then transported down to the nipple through a very fine series of ducts. And it's the lining of those ducts where the majority of breast cancers form. So if you look at a normal duct, you have a single layer of ordered cells around the entire perimeter of that duct. When these cells begin to grow abnormally, they start to take on the properties of cancer. And when they truly become cancer-forming cells, filling the entire duct and growing in an unregulated way, they become a pre-invasive cancer, a ductal cancer, ductal carcinoma in situ, so DCIS, sitting within the duct. It does not become truly invasive breast cancer until it acquires the ability to break through that wall of the duct and move out into the surrounding tissue and potentially out towards the lymph nodes that drain from the breast. That's when it becomes invasive breast cancer. So in both situations, DCIS, pre-invasive breast cancer, and in invasive breast cancer, radiation therapy has a role to play. So when we look at the anatomy of what we're talking about here, we're talking about radiation treating the breast tissue itself, or the area where the breast tissue was in the case where the breast is removed through a mastectomy. In some situations, we need to add radiation there for microscopic residual disease. And we're also talking about areas where the cancer can travel into the lymph node system. If you imagine the lymphatic system of the body as a kind of parallel circulatory system where infections and organisms, foreign organisms can be drained towards these lymph nodes and killed. Breast cancer, or cancer cells in general, like to use that lymphatic system to travel away from their point of origin and move out into the rest of the body. So if breast cancer moves into the lymph system in the region, we can treat that cancer there and potentially keep it from moving to more distant places. For the breast specifically, we're talking about the lymph nodes here under the arm, the axillary lymph nodes. And these nodes are contiguous with a chain of lymph nodes that moves up into the low neck. And all of this potentially would be treated with radiation therapy, typically in more advanced cases. And then you have a parallel chain of lymph nodes over on the other side of the breast next to the breastbone, the sternum, and that also drains from the breast tissue and is an area that we need to treat with radiation, usually in more advanced disease. So why do we need to use radiation at all? Why can't surgery or drug therapy such as chemotherapy or hormone blocking therapy take care of the situation? What does radiation therapy add? So in a situation where you have microscopic residual after surgery, that is, you say remove a lump of cancer out of the breast, there are cells still behind in that fine network of ducts within the breast, and they may have traveled quite a ways away from the area where the breast cancer started. And to try to chase all that with surgery can be pretty morbid. So there was a study done some decades ago where they tried to remove an entire quadrant of the breast for a very small breast cancer to see if that would sufficiently lower the risk of recurrence. And it didn't. The recurrences were still high, and radiation therapy still had a benefit. So for early stage disease, you'd have to remove the entire breast to get to the point where radiation wouldn't be needed, except in very low risk cases that I'm going to be talking about later. And even in situations where you remove the entire breast, there can be high risk situations where you still need to treat that area where the breast was because there's recurrence risk there. Chemotherapy and other drug therapies, on the other hand, are very good at attacking individual cells that have, say, spread throughout the body, but there may be left behind in the breast, a little ways away from where the cancer started, too large of a disease burden to be eradicated by chemotherapy and other drug therapies. And this has been borne out in clinical trials that show that radiation has a benefit above and beyond those other two ways of treating cancer. So when we look at early stage disease, the primary benefit is to keep the cancer from coming back in the breast, okay, to lower the recurrence rate. Secondarily, it can have a benefit in terms of survival. And there was a large meta-analysis that was published about 15 years ago, a meta-analysis being a trial that looks at a whole group of trials. It pools that data together. And what they found is that looking at cases of cancer in tens of thousands of women, that for every 4 recurrences that were prevented, 1 death was avoided. So there's a more pronounced benefit in terms of local recurrence for early stage disease, but there is also a potential survival benefit. In more advanced cancers where you have a large tumor, lymph nodes involvement of the skin, then you talk about a really dramatic reduction in recurrence, about 2/3 reduction in recurrence rates when you add radiation on, even after the breast is removed, and about a 10% survival benefit. So this is why radiation still remains an important part of what we do in the treatment of breast cancer. I often get asked, how is it that radiation works? What is it that it does to kill the cancer cells and not unduly harm normal cells? And, not to frighten you too much with physics and biology, but just to give you a basic sense, radiation therapy, the vast majority of radiation therapy is X-ray treatment. X-rays are simply photons of very high energy. And those X-rays hit the tissue of the body. Sometimes they can, basically the damage that they cause is to DNA. Sometimes they can directly go and break a DNA strand, but most of the time what is happening is that photon or X-ray comes in, strikes the tissue, releases electrons from the tissue. Those electrons then fracture water molecules that sit next to DNA strands, and those fractured water molecules then can bind to and damage the DNA. It can do this in normal cells. It will do this in normal cells as well as cancer cells. The difference comes because cancer cells are really stripped down versions of normal cells. They do not have the repair mechanisms for DNA that normal cells do. And so when you give little bits of radiation every day, you are causing what we would call sublethal damage. So little bits of damage to the DNA strands in a normal, healthy cell are repaired, and that cell will be able to go on living. A cancer cell cannot repair that damage. That damage becomes cumulative, and it becomes so much damage to the DNA strand that when a cell goes to divide and grow and it tries to copy that DNA, it can't do it and the cell dies. And that's how you get that benefit of killing the cancer cells and not killing normal cells. The key to that has always been the biological models would always predict you have to give little bits of radiation each day rather than one large dose. So these inferior DNA repair mechanisms are the key to the cell kill for the tumors that we get, and the damage over time causes cell death in the tumor. The way we truly deliver this is through a machine called the linear accelerator, or the LINAC. And those of you who have gone through cancer treatment or have had family members who have gone through cancer treatment will be familiar with a machine like this. This is basically the workhorse machine that you would see in the vast majority of radiation departments across the country and the world. These produce X-rays or photons. They can also produce electrons for treatment in certain situations, but that's not really what we're talking about today. And the way this machine works, if you take the basic outline of a linear accelerator or LINAC, the X-ray beam is generated here in the head of the machine. And up inside the head of the machine, we have a series of metal leaves that can shape the beam as it travels out of the machine. So you can get any shape you want by moving these individual little leaves in and out of position. And then in turn, that area, the head of the machine, can rotate to help conform the shape of the beam to the target that we want to treat. This entire apparatus, the gantry of the machine, can then rotate about a pivot point so that we can angle the beam in any direction we want relative to the patient who is sitting here on this treatment couch. And then we can even move that treatment couch in position because it's sitting on a carousel. And so that can move back and forth so we can get beams coming from any angle that we want. The key is that each of these beams is being delivered in series. The machine comes from one side, delivers a radiation beam, comes to the other side, delivers a radiation beam, and that's how, through multiple beams, we can accurately treat the target sitting inside of a person's body. So to give you a sense of how that works for breast cancer treatment, if we take the outline of a person who's lying on a treatment couch, and this would be the corresponding CAT scan that we see down in the lower left-hand corner, all right? So a CAT scan is basically a slice through a person's body. This is taken through a slice right here at about nipple level, okay? So imagine that a person is lying on their back such that their head is inside the computer screen and their feet is coming out of the computer screen towards you. This would be their backbone. This would be the breastbone or the sternum. This is their right side with the right lung, the left lung, the ribs on either side, the heart, and then we have the right breast and the left breast. So if we wanted to give radiation treatment just to that left breast and avoid other tissues, we can angle a radiation beam so that it's kind of skimming along the chest here and encompassing that breast. So if you can see on this diagram here, this beam is laid out here on this CT slice, and it's encompassing the breast, And it's not treating much lung. It gets a little bit of lung because, of course, it's a straight edge to the beam and the breast tissue curves around the rib cage. So you're getting a little bit of lung that's treated in there, but a very small amount that really, in the vast majority of cases, is not going to cause any harm to the lung. And then the heart is out of the way because we can see that on a CAT scan and angle this beam such that the heart is out of the way. If we then put a beam on the other side so that these beams are opposing each other, we can get a nice uniform dose across the breast tissue. And we can see that whole color wash in red is showing us that it's a uniform dose. No area is too hot, too cold, and all of the breast tissue is being treated. That's traditionally how we go about treating the breast with radiotherapy. It gets a little more complicated when you say, well, in a more advanced case, now we need to treat all those lymph nodes in the region. Here's a case of someone whose breast has been removed through a mastectomy, and the area of concern is here in red, the chest wall where the breast used to sit. So we can again angle a couple of beams that give us a nice dose distribution across that area of the chest wall. But what about these lymph nodes? The lymph nodes up here in the neck, the ones here in the axilla under the arm, and then that separate lymph node chain over here next to the breastbone. We can get that one next to the breastbone with these beam arrangement that we see here. Then we've got to add some extra beams up at the top to treat these lymph nodes. And that gets a little tricky with the geometry because you have to have, outlined in green here, you have to have an edge where these beams don't cross. If they cross, then you're going to be double dosing tissue. And so that's where it can get a little bit complicated. You don't want to see any of these light images crossing over and showing double dose. So that's, if that were to happen, that's what we call a match line fibrosis, and that can cause extra toxicity. Okay, so that comes important a little bit later. So when we talk about delivering radiation treatment, I said dividing up the dose into little bits each day helps us to limit the damage to normal tissue. So traditionally, going back to the 1970s and even earlier, the way you would divide that up is by giving one treatment per day, 5 days per week, over about 5 weeks total. And that would be treating the whole breast or the whole breast plus the lymph nodes. And then you might give a 6th week where you focus just on that spot in the breast where the cancer had started. So starting in the 1990s, we had data developing primarily in Britain and Canada showing us that we could give a little bit more dose per day and shorten this up. Maybe do this in about 3 weeks to the entire breast and lymph node area, and then have a 4th week just to the area of the tumor. And now we have data that's got 30+ year maturity showing us that actually this is a very well tolerated treatment, that the cosmetic outcome, the appearance of the breast afterwards is probably a little bit better. And so this really has become the standard in how we treat the breast alone. When we're talking about adding on those lymph nodes up above in the neck and under the arm, and we have that match line issue, there's still potentially a little added toxicity by shortening this up. And this has not yet become standard uniformly across the United States, although the data is maturing and you are seeing many centers starting to use this. And I would imagine that over the next 5-10 years, you're going to see this more uniformly used in even those cases of breast cancer. What is interesting is we now see cases in early stage disease where we can shorten this way up and give a significantly greater dose per day for a total of 5 treatments, either given once a week for 5 weeks or once a day for a single week. And we have 10-year plus data showing that for early stage, very low risk disease, particularly we're talking about usually older patients or someone who's especially frail, where travel can be difficult, or they're coming from a distance. There's data that's not as mature and established as some of this earlier data, but this is a technique that we are using to shorten that treatment up when it is useful to do so. All right, taking a step back a little bit and just asking the question, does everybody need radiation in addition to surgery and the other treatment modalities? Are there cases where the benefit is such that we can skip it and it's not going to make that big of a difference? So if we look at, for starters, early stage invasive disease that's low risk based on biologic factors and clinical factors, and we just remove that lump of cancer, if you look at all comers in that situation, that risk of recurrence is about 35% going out 10 years, okay? For DCIS, for pre-invasive cancer, it's about 2% per year risk if we do no other treatment after removing that lump of cancer, about 24% at 12 years. Half of those recurrences when it comes to pre-invasive cancer are going to switch over to invasive breast cancer. Okay. Now we add on radiation, we cut this risk almost in half in terms of invasive disease. And in terms of pre-invasive disease, we do cut it in half by adding on radiation. And now instead of half of those recurrences coming back in the invasive form, now it's only a third. So we significantly cut down that risk of recurrence as invasive breast cancer. So that's the general logic of using radiation therapy in sort of all comers. But can we trim that down and find a subgroup of folks for whom that benefit isn't so pronounced? So there have been a couple of trials that have looked at that. And what we've found out is that for women who are 65 to 70 or older, who have relatively small tumors with good surgical margins, meaning there is no cancer cells touching the edge of the lump of tissue that's removed from the breast, and the biology is favorable, which is to say the cells don't appear to be dividing very rapidly under the microscope, and the markers for the cells appear to be favorable. They can respond to hormone blocking medication, and there does not appear to be any regional lymph nodes involved. In those situations, for women who take hormone blocking medication, and this is important, they have to be taking hormone blocking medication, the risk of recurrence without radiation is about 10% at 10 years. So not really that high. It's lower if we add on radiation. It's about 2% at 10 years. But many women would look at this number and say, okay, 90% chance that I'm not going to have it come back in 10 years without the radiation. I'll take that. And that's a reasonable choice. This is where it becomes a real personal decision about what level of risk you want to take on. Some women would choose to really minimize that risk and have the radiation, but perfectly reasonable to skip the radiation in this situation, as long as a woman is taking that hormone blocking medication. So that's the case for low risk invasive disease. For pre-invasive disease, DCIS, somewhat similar criteria that's been teased out. It has to have that favorable biology. You have to have those negative margins. You have to have a width of normal tissue around that lump of cancer that's taken out. And again, small tumors. Typically, we're talking about women who are not premenopausal. And then, the data seems to indicate that that risk of recurrence is maybe only 1% per year. It's still very real. So 12% of 12 years, this data does not appear to plateau. So you get out 25 years, it's a 25% risk. And it will be lowered, again, cut in half that risk of recurrence if you add on radiation. But some women in that situation might look at this and say, I'm willing to take that risk. Depends where they are in their lives, other health issues, how old they are, all that kind of thing. But it becomes a risk reduction conversation. Now, there are some tools that can help us now in figuring out if the biology of the pre-invasive cancer is favorable for this as well. There are a number of commercial tests that are available. This is one that we've been using at Bay State now for a little while, called the Decision RT test. And we like this one because it actually has been validated on a very large group of tissue samples from a large-scale trial where they compared the biology of those tissue samples with the outcomes of the patients on the trial. And so this test is looking at both clinical features, patient's age, whether or not it was something that could be felt in the breast, the size of the cancer, and did it have a good margin around it. It's taking those traditional clinical factors and combining it with a profile of the genetic makeup of that cancer, 7 genes in particular, and what their status is. And what you end up with is a score sheet that gives you a predictive value for your likelihood of recurrence. So that translates into a prediction for any type of recurrence, whether it comes back as pre-invasive DCIS or invasive. And they can look specifically at recurrence of invasive disease. You'll notice in this one, you have someone who has a very low risk score, and that translates into not a very high risk of recurrence at 10 years, about 10%, and it's lowered a little bit with radiation. So might be a reasonable situation to say, you know what, I'm going to skip the radiation in this case. A higher risk presentation, a higher score, now you see this dramatic benefit to radiation therapy and dropping down to what's maybe an acceptable level of risk of recurrence at 10 years of about 5%. You can even have dramatically elevated scores where even with radiation, the risk of recurrence is high. And in that situation, a woman might choose to have the breast removed. This is an additional tool that we have. It doesn't tell the whole story. Sometimes the clinical picture is such that it's compelling to do or not do radiation even without this test. So in my practice, I'm not recommending this on everyone, but there are definitely situations where it's valuable, and where if someone's trying to make that very personal decision of whether radiation makes sense for them, this can be a useful tool to make that decision. Okay, so if after all that we still need to deliver the radiation treatment, how are we making it as safe as possible? What are the newer techniques that we can use to make that happen? So the first on that list is what I had mentioned at the beginning, this deep inspiration breath hold, which sounds simple, and it actually is kind of simple. The whole idea is you have someone hold their breath for a few seconds, about 20 seconds, while they're lying on the treatment table. And this fills the lungs and pulls the heart down and away from the area you want to treat. So you can see in this example how now the heart is sitting lower than this slice, and it is well away from the area of treatment. There are a number of commercial mechanisms available to radiation departments to allow this to happen in a safe manner. That is, it's of course important to know that the person has held their breath at the appropriate position before you turn on the radiation machine. The technique we use at Bay State is with a series of infrared cameras mounted in the treatment room that can monitor the surface position of patient's chest. And so you can see here on the monitor, here is the patient on the camera, here are the lines outlining what position they should be in, and the camera is telling them that all these dimensions are in the green, they're where they need to be, and the X-ray treatment can proceed. If a person lets their breath out and these parameters fall into the red, the machine shuts off. So that's your safety mechanism. So this is a good tool for us. Like so many of the other things I've talked about, it's not for everyone. Not everyone can hold their breath for that long. Not everyone's anatomy makes it amenable to this. Sometimes it doesn't make that big of a difference when a person holds their breath. And so it's not something we're using on everyone, but it's a tool that we have in our armamentarium for treating with radiation. Another is the very simple idea of laying a person on their stomach rather than having them on their back. Once you're laying on your stomach on a board with a cutout for the breast to fall away from the rest of the body, this allows us to give radiation dose to that area and spare the adjacent tissues. So here's someone lying on their back with their breast falling out to the side. And again, this depends on a person's anatomy, but potentially if the breast is falling out to the side, now we're treating a lot of the shoulder area as we're trying to angle off of the heart, versus if they're lying on their stomach, now that breast tissue is falling away and we can steer away from the lung and the heart together and get good uniform dosing. Not everyone can lie on a board like that. You really can only use this for early stage disease, but it is another way that we have to minimize radiation dose to tissue that doesn't need to see it. This method I talked before about altering the beam itself with intensity modulation. So to describe what this is, because I think you hear about this in the news a lot, so it's good to kind of get a sense of what it is that we're talking about. Remember I talked about in the head of the machine here sits this series of metal leaves that can give you any shape you want to be conformal to the target within the body. So, and then if you rotate the beam in an arc, you can be making any shape that you want, moving, as the beam is moving in an arc form. So if we look at that head of the machine, what we call a multi-leaf collimator, and you imagine that that area inside this opening can be divided into a whole bunch of smaller squares. And because these leaves can move in and out all the time while that beam is arcing around, we can assign each of these squares an amount of time that the beam is actually open or closed in that square. So this square over here, we could have open for, say, 80% of the time, because the leaf isn't going to block it for 80% of the time, versus this leaf here, where now that is blocked for more of the time. And so each of these little squares sees a different amount of radiation pass through it over the time that the beam is on. That's what we refer, that is intensity modulation. If we kind of look at an example of what it would look like to, as if we were exposing a piece of film, and I'm going to just move this back, and so try to get this video to play for us. So this is the leaves moving in and out, in and out, in and out, and the different squares are all seeing a different level of light. And in this case, we can produce a picture. But the idea is that it allows us, with the radiation passing through all these different squares, to sculpt the dose very precisely within the tissue. And I put this diagram in here just to show this cartoon, where you see here the X-ray machine rotating about a target within the breast. And now, as this thing is arcing back and forth and all those leaves are moving in and out, it is sculpting the beam very precisely for the target in the breast. And what that looks like in the end, here is an example of a standard radiation beam where you just have an open X-ray from this side, an open X-ray from this side. It's just a uniform dosing across the breast area. But in order to treat these lymph nodes next to the breastbone right here, we have to spill into the opposite side to make that work. Now, if we use that intensity modulation that I was talking about, in this case, we're talking about volumetric modulated arc therapy because it's arcing around the person. Now we end up with something that's a bit more of a sculpted dose, where we're coming and curving around with the chest, giving extra dose right here where we want it at these lymph nodes, and not spilling over into the breast, the other breast so much. So that has an advantage for us, particularly in more complicated cases where we are trying to dose lymph nodes in the region and work with especially challenging anatomy. There are downsides to this too. This is why we don't use it on everybody. You'll notice that over here on this side, the low dose region, which is the green to blue area of dose, it's very thin. Over here, it's spilled out a little bit and into some areas that it wasn't involving before. And that's because rather than just having the beam fixed here and here, it's arcing all the way around. And so it is spilling the low dose, the very low dose of radiation into some other areas that wouldn't see it otherwise. So there's a bit of a trade-off, but it's a technique that we can use and are using for treating more advanced cases. Okay, partial breast radiation. So this is very simply the technique of treating just the spot of cancer in the breast. We've had that ability for quite some time. There are advantages and there are disadvantages to doing it this way. So on the pros side, typically when you give just a concentrated dose of radiation to a small area of the breast, you can do it in less time. You can do it in fewer treatments. And this was particularly advantageous in the days when we were giving 6 weeks of radiation to everybody. Obviously, by definition, there's less tissue treated. It's just that smaller portion of the breast. And it is the preferred method to radiation retreatment. That is someone who's had radiation years ago to that breast. They don't want to have that breast removed with a new cancer that's come. If it's an early stage cancer, we can target just that area safely. We have data that shows that that can work very effectively. And the outcome in terms of cosmetic, appearance is still quite good. On the con side, so this is a not for everyone. It is a narrow eligibility. It's really for low risk tumors, kind of similar to the criteria for omitting radiation therapy or short course radiation therapy that I showed earlier. So the benefit in terms of that shorter time starts to fall away. Then some of these methods for partial breast radiation are more invasive, and I'm going to show examples of that in just a moment, but they can involve placing an apparatus inside the breast temporarily to deliver a dose that way. And I would say that the data on the use of this has mixed results in terms of the cosmetic outcome. There's a logic that would say you're treating less of the breast, and therefore scarring in the breast and effect on the skin and everything will all be less because it's a smaller area of the breast. And there's some data that shows that to be true. On the other side, the idea that you're dosing a high dose in one part of the breast and little or no dose in another part of the breast, it's not uniform, and that may actually cause a little bit of a worse outcome. So there's a little bit of conflicting data on that. Okay. At Baystate, what I can tell you is because the criteria for this is so similar to the short course whole breast radiation treatment that we have, we're generally not using this except in this situation where we have to give repeat treatment to a previously radiated breast. But there are centers who are using the partial breast irradiation more broadly around the country. I talked about ways in which you can put a radiation source inside the breast, either through a number of catheters that can be placed within the breast. That's how it was done, decades ago. Not so common now. There are applicators that can be placed within the breast that have a balloon apparatus attached to it, and this allows you to put a radioactive source in there for just a few minutes, a couple times a day, and get treatment done in, say, just 1 week. A similar apparatus that doesn't use a balloon that can be placed at the time of surgery or shortly after surgery and then simply removed in the office. These are techniques that are very, very conformal. The dose is really limited right to where you want to give it, but it's invasive, and there's always a little bit of risk of infection and bleeding and all those sorts of stuff with an invasive procedure. You can give radiation to just a portion of the breast through a standard treatment X-ray machine, the linear accelerator that I had shown you earlier. You can set up an array of beams that conforms to that one area of the breast that you want to treat, and then have nice uniform dosing in just that area. That's the method we're using at Baystate when we need to do partial breast irradiation. Again, we're only really finding this useful in kind of very limited situations. I did want to make a mention of a technique called intraoperative radiation therapy. This is something that was in the news. NBC did a piece on this a couple of weeks ago, and I felt I should give a moment to that, just because I think their presentation in the news piece was a bit skewed in terms of showing this as if it's sort of the secret technique that your radiation oncologist doesn't want you to know about, and that they have in other countries but not here. This is a technique that's been around for a while. It basically uses it's a nice idea. It's a machine that delivers a single dose of radiation therapy right to the area where the cancer was sitting at the time of surgery. So the surgeon goes in, makes an incision, removes that lump of cancer. This device is placed there for just a few minutes in the operating room, delivers a dose of radiation, one dose of radiation, and you're done. Potentially, you don't need any other radiation after that. The problem with this technique is there have been a couple of trials that have looked at this, one of which has very short follow-up, so we really don't know the cosmetic outcome and the efficacy of the treatment, how well it worked in the long term from that trial. And the one that had longer follow-up really did show the outcomes, the recurrence rates were significantly higher when you use this technique versus standard radiation. The way this technique works is you can only dose the radiation so deep in the tissue. If you try to go deeper, you're really going to overdose the tissue that's right at the surface. So it has a one-size-fits-all aspect. And the real key problem with that is you don't know how deep, if there are residual cancer cells at the edge of the cavity of the tissue removed, because it takes a few days after the surgery before the final pathology result comes back. So when you're delivering this, you don't know if there's still more cancer for which a person has to go back for more surgery. You don't know if the lymph nodes are involved until a few days later. And when that final information comes out, it might turn out this person might still need whole breast radiation or radiation to the lymph nodes. And in those cases where they end up with both treatments, the scarring and the cosmetic effect on the breast is truly much worse. So in the US, this technique is being practiced at a few centers. It is considered investigational by national cooperative groups, and I would say for good reason, given these factors here. So I would urge caution when you're presented with this particular option, despite how it's presented in the media. So that is my presentation for this evening. And again, I'm really happy to have been able to share all of this with you. And I'm happy to take any questions.
Thank you, Dr. Kaufman. That was very informative. We do have a few questions, and folks can feel free to still submit some as we're going through. We'll get started here. We have one question that says, do patients need to take the hormone blocking medication for the balance of their lives? I mean, I think meaning like the rest of their lives.
Mm-hmm. So no, typically at least 5 years with the hormone medication. There are situations where that may be beneficial to extend a bit longer, even out to 10 years. That is a discussion that a patient would have with their medical oncologist, because the medical oncologist would be overseeing that treatment. But yeah, it's not typically something that's given lifelong.
Thank you. And what is the downside of receiving unnecessary radiation?
Yeah. So, radiation, of course, any of these treatments is not without risk. So, when I was showing that display of, say, that low dose spillage into areas like the lung, it does cause a little bit of scarring in the lung. And, that area is very limited. But you certainly wouldn't want to have that done unnecessarily. It's kind of one of these, risk-benefit ratios. So if there's an area of the body that needs to see the radiation treatment because the risk of cancer coming back is high, that's fine. But you really wouldn't want to spill the dose unnecessarily into other areas. People do ask me about the risk of, well, doesn't radiation cause cancer? There is a little bit of risk of radiation causing a brand new cancer. It's a very, very low risk, but you wouldn't want to have it unnecessarily. So that's basically the reason for it.
Thank you. To how large or small can radiation be applied?
How large or small an area? Um, so so radiation is generally not given to such a large area that say it's, half the body or the whole body. Um, there are some special situations, but it's not a technique similar to what we call systemic therapy, drug therapy that goes everywhere in the body. And there's reasons for that. Even low dose radiation to the entire body can affect the bone marrow. And so that's one reason you wouldn't want to give it to a very large area. However, you can treat, depending on the way you deliver the radiation, to a pretty large segment of the body. So in the case of breast cancer, treating the whole breast region and all those lymph nodes I talked about, as long as you're dividing that dose up relatively safely, you can treat all that area very safely. When you start getting into very small areas of treatment, where you're just treating, say, a lump of cancer and nothing else, that's where you can get a little fancier and start giving very, very high doses of radiation, because effectively the radiation you're giving is ablative and everything within the target area is what you want to kill. But yes, there's a range and it's a pretty broad range in terms of the size of the target.
Thank you. We had another person write, I was able to do the breath holding radiation. Thank you for offering it. So, not a question, but
Great,
just a comment there.
great,
Nice
glad
to
to hear.
hear. And then another question, there are a lot of options. How do you recommend a patient begin the decision making process?
So I think it's really key to sit down and have a conversation with your physician, because our job as the physician is really to be your guide going through the cancer journey. We're not you are the one making the decisions for your life and for your body, and our job is to give you the best information to do that. And so I've presented a whole range of things here, but they don't all apply to everybody. And so our job is to really kind of hone that down and say, well, here's what really, here's the whole palette, and then here's what kind of makes sense for you and why. So I think that's really key, is to talk with your doctor, because if you just start going on the internet, you're going to see a zillion things, and you're really not going to have any sense of what's good and what's bad.
Absolutely. Is there a training to help patients get ready for the breath holding technique? Anything
Yeah,
that you recommend?
Yeah, so I mean, it's training that we do in the department, and so it's pretty simple, really. We go through a few practice sessions. Yeah, one can try holding one's breath at home, and really 20 seconds is what we consider ideal in order to have enough time for the beam to do what it needs to do. Um, but when someone comes in here, we'll typically go through a little bit of training with them, and I do kind of emphasize, this isn't like, well, if you can't do this, your treatment's going to be suboptimal. We have other ways of dealing with that if one can't do it.
Thank you. And can a person have radiation twice in the same breast?
Yeah, that's a great question. The rule of thumb has always been no, that generally speaking, you don't like to give repeat radiation to the same area of the body, because normal tissues do have a lifetime tolerance to how much radiation they can get. However, if enough time has passed, there is some recovery with that. And the point I was making a little bit earlier about the scenario where a woman, say, had breast radiation some years earlier, now she has a new spot of cancer that's removed, and she doesn't want to have the breast removed, we can give repeat radiation, but we keep it to a smaller area, just that portion of the breast that had the cancer. And in those situations, there's been very good outcomes. So generally, we try not to do repeat radiation, but we don't rule it out. And given the specifics of any given situation, we may be able to find a way to do it.
Thank you. What are some promising radiation treatment options on the horizon that you are excited about?
Yeah. So there are some methods for tracking the changes of the tumor within the body as someone's going through radiation. It's not so applicable in breast cancer because in breast cancer the lump of cancer has already been removed prior to the start of radiation treatment. But there are methods by which we can, on a daily basis, watch the tumor shrink and shift our radiation accordingly, and that's kind of an exciting thing on the horizon. In terms of breast cancer treatment, I do think that some of these shorter courses of radiation are becoming more standard, and the way that we are conforming the dose is becoming a bit more broadly applied. So I think these are some of the things that I'm excited to see shift our field over the next few years.
Great to hear. Thank you. That was actually our last question, it looks like. So thank you, Dr. Kaufman, for your presentation. We appreciate it. No, another question came in. So we have some time. So if you don't mind, we'll
Sure.
keep going. Is the type of cancer what determines the size of the dose?
Yeah, so generally speaking, for certainly for breast cancer, it's one dose that would be given for no matter what type of breast cancer it is. I talked about ductal cancer, invasive ductal cancer. That's what the majority of breast cancers are. There are some different types, lobular cancer and some other cell types that are treated in the breast as well. But the radiation dose is the same for those. For other disease sites, for other cell types, there's different dosing. But for the breast, it's pretty much all the same.
Thank you. Going to just pause for a moment if there are any other questions. Um, I have a thank you. So I think we might be good with questions. So thank you, Dr. Kaufman, for this presentation. Very informative. And thank you to everyone for joining us tonight. And have a great night. Thank you.
Great. Thank you all again.